In this video, we are going to discuss on ADHD related disorders. To understand the antidiuretic hormone and the related disorders, you need to have a sound understanding of the basics of how the ADH works and what are the prerequisites for ADH action. We already saw the receptors and the different types of aquaporins in the basics of the postpituitary video itself. But in this particular video, we're going to concentrate on even more basics. At the same time, we'll be discussing on one very important ADH related disorder called SAADH, again, which is a very important topic for your exams. So first, let us start building step by step. So we'll complicate later on, but before complicating stuff later, let us understand things in a very, very simplified fashion. So I've drawn the nephrons here for you. So why I've drawn three different nephrons, let me tell you, because you have to understand some basics about the diuretics and about the urinary concentration also, because by this principle only you can understand the SAADH and how these osmolar changes happen in the urine. And the real concept on physiology of the nephron and the diuretics will be dealt separately in the nephrology chapter, but this is just an overview for the sake of understanding the particular video. So let us move on. So first, how the ADH is going to act. You know the ADH is going to act in the cortical and the medullary collecting duct. That is the predominant site of ADH action. But before that, we have to know what are the water permeable and what are the water impermeable regions of the nephron. So let me draw. This is the water permeable region of the nephron. So I can write this blue shaded area. I can call them as water permeable regions of the nephron. So what are the water permeable regions here? So your PCT, proximal columnar tubule, as well as the descending limb of the loop of the Henle serves as a water permeable area for sure. So in this particular segment, if you see what is the solute and water movement, PCT will have solute movement as well as PCT will produce water movement. So since you are removing both solute as well as water from the glomerular filtrate, here the PCT will neither concentrate the urine nor it will dilute the urine. So that is why PCT is supposed to be something called isoosmolar segment, which means the urine will neither be concentrated nor be diluted here. It will be isoosmolar. They won't make any much changes in the urinary concentration, even though maximum amount of water and maximum amount of solutes are absorbed in the PCT only. For example, all the solutes are maximally absorbed in the PCT except for the magnesium, which we'll see, all these things we'll see later in the nephrology section. But even though the urine that is produced by the PCT is isoosmolar because they remove both solutes as well as water from it. But the descending limb of the loop of Henle is actually impermeable to ions. They are permeable to water, which means they absorb a lot of water, alright. So because they absorb a lot of water, they are going to concentrate the urine. So that is the reason why this descending limb of the loop of Henle is often referred to as the concentrating segment of the nephron. So because they are going to increase the urinary osmolality and they are going to concentrate the urine by removing more water, and they don't remove any solutes at all, which means the urine is going to get concentrated there. And now I can draw the water impermeable regions of the nephron. So this thick ascending limb or the ascending limb of the loop of Henle simply and the distal convoluted tubule are supposed to be the water impermeable region. So which means these areas are water impermeable, the red shaded areas, which means they cannot absorb water, but they can absorb ions. So which means they are going to absorb the solutes, ions. For example, the most important pump that helps in absorbing the ions in the thick ascending limb of the loop of Henle is what we refer to as NKCC2, otherwise referred to as sodium potassium 2-chloride transporter, which is a very famous transporter that is the target for your loop diuretics. And the most important transporter that is seen in the distal convoluted tubule, DCT, is the sodium chloride transporter. That is very important. Again, this is a target for thiazide diuretics, and these are also called as thiazide sensitive transporters. So these are the ones that are important for absorbing the ions, solutes in the distal convoluted tubule, which means what ideally here is happening is you are leaving only the water behind and you are absorbing the solutes. So if you are leaving only water and you are removing solutes from a particular solution, you are going to result in dilution of the urine. That is why the thick ascending limb of the loop of Henle and the DCT is often referred to as a diluting segment of the urine, which means they are going to lower the urinary osmolarity. Clear? So they're going to dilute the urine because they leave only water and they absorb only the solutes. So in that, the most important area is the thick ascending limb of the loop of Henle, which is the major diluting region of the kidney. Clear? Of the nephron. At the same time, it is also referred to as this medullary diluting segment. This thick ascending limb of the loop of Henle is also referred to as the medullary diluting segment because it's present in the medulla. Similarly, this DCT is also referred to as the cortical diluting segment because this DCT is present in the cortex. They are also called as cortical diluting segments. They are going to dilute the urine. Clean. Now, I'm going to shade this area. Why I'm shading this area in pink? Because this area which I shaded in pink, these are the cortical collecting ducts and the medullary collecting ducts and maybe the distal most part of the distal convoluted tubule. All these things will come under this distal nephron. This distal nephron, why shaded in pink is because they are like not permeable to water also, but they are not impermeable to water also. So I'm not confusing, it is true, which means the permeability of this collecting ducts and the distal most part of the DCT is dependent on one particular and very, very important hormone that is called antidiuretic hormone, which means I can write this collecting ducts and the distal most part of the DCT are selectively permeable, which means their permeability will depend on the availability of ADH. If ADH is available, they will be permeable to water. If ADH is not available, they will not be permeable to water. Let me write. So if ADH is available, they will be permeable to water. With the help of aquaporin 2 channels, we have studied already in the basics of postoperative video. So ADH is not available, they will not be permeable to water and water cannot be reabsorbed. In fact, water is leaking into the urine, which means only if ADH is available, this area will concentrate the urine. If ADH is not available, this particular area will not concentrate the urine and they are going to pass dilute urine only. Clear? So if you take into consideration, leave the amount of solutes or amount of water that is reabsorbed by each and every segment, but let us assume what will be the amount of urine that is reaching the each and every segment. Suppose if 125 ml per minute is reaching the proximal columnar tubule as a glomerular filtrate, by the time it reaches the thin descending limb of the loop of Henle, it will become like around 44 ml, which means only 44 ml of urine will be reaching the thin descending limb of the loop of Henle because of the water and solute absorption in the PCT. Still the urine will be isoosmolar. By the time it reaches the diluting portion of the nephron, that is the ascending limb of the loop of Henle or the thick ascending limb of the loop of Henle, the amount of urine that you are going to get is only 25 ml because you are absorbing a lot of water in the descending limb of the loop of Henle. So only 25 ml of urine approximately will be reaching the diluting portions. And when it reaches the collecting duct, so hereafter the 25 ml will remain throughout because the water is not much absorbed in the thick ascending limb or the DCT. It's only the solutes that are absorbed. So the amount of urine will not much change in the diluting portion of the nephron. So again in the collecting duct, since water absorption will happen in the presence of ADH, how much is the amount of urine that will be coming out of the nephron and the kidney will be dependent on what is the availability of ADH. Suppose if ADH is available and ADH is acting at its full capacity, they'll produce only 0.2 ml of the urine, which means urine will have very high concentration and they will pass very little urine only. Suppose if ADH is completely unavailable, totally not available, I'm telling other extreme. In this condition, almost 20 ml of urine will be passed, which means you can see the time it reaches the diluting segment itself, it's 25 ml only. So through the diluting segment, there is not going to be much change in the amount of the urine. But in the collecting duct, in the cortical and the medullary collecting duct, the amount of urine should be, how much it should be produced is decided by the ADH only. And how much of the urine that should be concentrated, how much it should be concentrated is again dependent on the ADH action only. Suppose if ADH is full, only 0.2 ml of the urine will be produced, which means they are going to produce a very, very hyperosmolar urine and very highly concentrated urine. Whereas if ADH is completely unavailable, they are going to produce a very poorly concentrated urine that is going to have a very low osmolarity only. So now you have to understand here the concept of free water clearance. Concept of free water clearance. It is not very important to know the free water clearance in the diluting segments of the nephron, because these events till the collecting duct, till you reach the ADH action, till that particular portion, the events that are happening are relatively fixed, which means in PCT you produce isosmolar urine, means you are going to produce isosmolar urine only. In descending limb of the loop of Henle, you are going to produce concentrated urine, means you are going to produce concentrated urine only. Similarly, in the thick hustling limb of the loop of Henle, if you are going to produce dilute urine, means you are going to produce dilute urine only. Which means these events that are happening till the distal convoluted tubule and distal part of the nephron is relatively fixed. You cannot change them under physiological circumstances. Pathologically, you can change by giving some diuretic agent that block these pumps. I'm not denying that fact. But physiologically, these events that are happening till the distal most part of the DCT is relatively fixed. You cannot change them, physiologically at least. But physiologically, the one thing that completely changes the game and completely changes the urine osmolality and completely changes the amount of urine that should be produced under physiological circumstances is the ADH and the distal part of the nephron. That is the distal most part of the DCT and the collecting ducts, cortical and the medullary collecting ducts. So very, very clear about that fact. So that is why the free water clearance means we are actually talking about the ADH action and the collecting duct. See, till that it's fixed. So there's no point in talking physiologically about this free water clearance, but let us talk about the free water clearance only in relationship to the ADH. So let us see what's going to happen here. So when you have ADH action, let us assume, and when you don't have ADH action, what will happen? So when you have a good amount of ADH action or a full ADH action, there is going to be increased water reabsorption through this aquaporin 2 channels. That is going to reduce the water excretion. That is going to reduce the amount of water that is excreted in the urine. So you can see the urine osmolality will increase, or urinary concentration is going to increase. What I can tell is, because of reduced water excretion, so this I can even write it as the solute excretion will be more than the water excretion. They won't be in proportionate with each other. So solute will be more than that of the water. So since water is less and the solute is more in this urine, that's why the urine is concentrated, and this is what we refer to as something called a negative free water clearance. This is called a negative free water clearance. Clear? Very important point, negative free water clearance. Similarly, if ADH is absent and it's completely unavailable, you will result in very, very poor water reabsorption. And this ADH action is to absorb free water. It's not absorbing the solutes. Please be careful. They are not really absorbing the solutes. They are absorbing the water only. Clear? So there will be increased water excretion in this scenario. Because of that, the urine will get diluted. So urine osmolality will be reduced. So I can write here. So here the water excretion will be more than the solute excretion, which means the same amount of solute, but it will be diluted in a lot of water. So in the absence of ADH, we are going to call this as a positive free water clearance. I can write positive CH2O because it's a positive free water clearance. So this is the basic principle. ADH is present, you have a negative free water clearance. ADH is absent, you are going to have a positive free water clearance, more water than required for that particular solute. Okay. Suppose there is a area where solute excretion is equal to water excretion. So which means it's exactly proportionate to what amount of solute is there, the same amount of water is also there. I mean, the gauge here is the plasma, we'll come back to that. So solute is equal to water. So in this condition, you can tell the free water clearance is equal to 0. It's neither positive nor negative. Free water clearance is equal to 0. So now I can write, since the urine is having increased osmolality, means here the urinary osmolality will be more than that of the plasma osmolality, which means I am producing hyperosmolar urine. I told that is the reason I told what is the gauge here. The gauge is the plasma. So here I can tell the urine osmolality is actually less than the plasma osmolality, which means here I am producing a hypoosmolar urine, not a hyperosmolar urine. Again here the gauge is the plasma, the comparison factor. Here, if the free water clearance is 0 and solute is almost equal to water concentration, which means the gauge is the plasma, we are comparing the plasma, which means indirectly it means the urine osmolality will be equal to plasma osmolality, which means I am producing a isoosmolar urine here, which means isoosmolar to plasma in comparison with that of the plasma. Whenever you tell the term free water clearance is equal to 0, which means you are producing a isoosmolar urine, means it can happen only in two states. Very common scenario where you get this high isoosmolar urine and no urinary concentration or dilution at all is when you use loop diuretics. Very, very important point. Loop diuretics will produce isoosmolar urine only. That's what the next concept we are going to discuss. Similarly, another condition which can produce isoosmolar urine. Urine is neither concentrated nor diluted because the kidney is destroyed. Kidney is not working. Renal failure, especially in CKD patients. In end-stage renal disease patients, the urine will be completely isoosmolar to that of the plasma. They produce less urine, all right, because of the poor GFR. Filtrate itself is very less, but whatever that comes in the tubule cannot be concentrated at all because they lose the concentrating ability as well as the diluting ability. That's why we call it as isoosmolar urine, CKD patients. So these are some of the concepts that you have to understand about the free water. ADH is a very, very important agent. Under physiologist comes, it changes the free water in the urine. Remember, till the ADH action, everything is fixed. I mean, ADH is something flexible. You can increase the ADH or you can decrease the ADH. That's why the distal part of the nephron is the most important, physiologically at least. They are the ones that alter the amount of water that is going to leak into the urine depending on your physiological demands. Suppose if you don't take sufficient water, obviously you cannot excrete more water, so urine will be concentrated, and the distal area is the one that is taking care of all these physiological cues and physiological demands. Clear? Now, let us take the second diagram. Why I put 3 diagrams? Let me tell, because I wanted you to understand about the importance of the loop diuretics. I'll tell you why I'm explaining about the loop diuretics and thiazide diuretics here. I'm not going to explain in detail about the loop and the thiazide diuretics, but I can give some vital and substantial data on why this is important for understanding your SCADH and diabetes insipidus, ADH related problems. For that, you have to understand one important entity called prerequisites for ADH action. So there are some things that are needed for ADH action. It's not like ADH will come and straight away act and they will promote water reabsorption. So yes, of course, ADH is important for water reabsorption. Then only this area will be having aquaporin 2 channels. So without ADH, they won't have aquaporin 2 channels at all. So of course, ADH is important for water reabsorption, but ADH is not the only thing that is important. There are few other things that determine the water reabsorption from the tubules. The most important determinant for water reabsorption in the tubules will be this medullary interstitial hyperosmolarity. So very, very important event. This is called a medullary interstitial hyperosmolarity. Very, very important. So as you go down, the osmolarity will increase. Right? You know that. The maximum osmolarity the humans can reach is approximately 1200. So that is the lowest, innermost portion of the medulla in the juxtamedullary nephrons. 15% of them are juxtamedullary, isn't it? So 15% are juxtamedullary nephrons are hairpin type of nephrons, and they are the ones that maximally concentrate the urine, and the maximum concentration that you can reach at the lowermost region of the medulla is 1200. And this is a very, very important principle to absorb water from anywhere in the tubule. Like it's very, very important, especially for concentrating the urine. This is so important. What I'm trying to tell is for absorption of water from the distal portions of the nephron through the action of ADH, you need ADH all right, but you also need this medullary interstitial hyperosmolarity to exist. Similarly, I told you this area of the nephron is completely water permeable. I told you they absorb only water, in fact, the descending portion of the loop of Henle. And the absorption of water in these areas is also dependent on the medullary interstitial hyperosmolarity, which means whatever substances you have or don't have, it doesn't matter. To absorb water, you need that medullary interstitial hyperosmolarity. That is the take-home point. So I'm coming back to one thing, but who is maintaining this medullary interstitial hyperosmolarity? That is the thick ascending limb of the loop of Henle. Very, very important area. By virtue of one very important pump called as sodium potassium 2 chloride transporter. They are going to take sodium, potassium and 2-chloride. Sodium, potassium and 2-chloride transporter. Very, very important pump because they take up the sodium and they concentrate the sodium in the medullary interstitium. And how they prevent this sodium from getting washed out, and even if it's washed out, what are the counter-regulatory mechanisms for that? All these things are a topic of pure neprophysiology we'll be discussing in the nephrology section. But now let us assume they are going to concentrate the sodium in the medullary interstitium. So this is the main reason for the existence of something called a medullary interstitial hyperosmolarity. And this is a very, very vital pump, even though they absorb only 25% of the sodium, but the PCT is the one that absorbs the 60% of the sodium. PCT, 60 to 65% of the sodium is absorbed by the PCT. And this thick acetylene limb of the loop of Henle is going to absorb only the 20 to 25% of the sodium. But still, this is a really, really important pump because the medullary interstitial hyperosmolarity that is generated by this thick acetylene limb of the loop of Henle by virtue of this NKCC2 pumps. These are called as NKCC2 pumps, which uses ATP, primary active pumps, is very, very important for water reabsorption elsewhere in the descending limb of the loop of Henle also, as well as from the collecting ducts also, distal portions of the nephron in response to ADH. So what I'm trying to tell is the urine is getting concentrated because of this medullary interstitial hyperosmolarity only. It's only the fact that in the descending limb of the loop of Henle, it's fixed, where water will be definitely reabsorbed if there is medullary interstitial hyperosmolarity. But in the collecting duct and the distal portion of the nephron, even in the presence of medullary interstitial hyperosmolarity, you need ADH, which means you need both to absorb water in the distal portions of the nephron. But in the descending limb of the loop of Henle, you need only this medullary interstitial hyperosmolarity because it is not dependent on ADH in the descending limb of loop of Henle. So, but the important prerequisite, even in the presence of ADH, you have to understand you need to have this medullary interstitial hyperosmolarity, which is actually maintained by the sodium potassium 2-chloride transporter. Okay. So now I am trying to tell one important point here. What if I am blocking this sodium potassium 2-chloride transporter? Fine. So what will be the effect of blocking this sodium potassium 2-chloride transporter, which means I am giving a loop diuretic like furosemide. We have a lot of drugs, isn't it? Furosemide, then torsemide, then bumetanide, then you have ethacrinic acid. So all these things are loop diuretics, but let us take a simple example, Lasix, that is a furosemide. So when you are going to give a loop diuretic, don't worry about whether urine is not getting concentrated or urine is not getting diluted. I'm not talking about that fact at all. The first thing you are going to lose is the medullary interstitial hyperosmolarity. This is what you are going to lose in the first place. You are not going to have this medullary interstitial hyperosmolarity, which means you are going to lose this particular phenomenon. So when you lose the medullary interstitial hyperosmolarity, remember, even in the presence of ADH, even if you have ADH, even sufficient ADH if you have, they cannot reabsorb this water. Very, very important point. They cannot reabsorb this water, even in the presence of ADH, which means I can also tell the loop diuretics, in the presence of loop diuretics, which means they abolish the medullary interstitial hyperosmolarity, they create a state of ADH resistance, isn't it? In a way, if you understand, even in the presence of ADH, water cannot be reabsorbed because loop diuretics abolish this medullary interstitial hyperosmolarity. So, which means ADH-induced water reabsorption is also lost. So, can I write like loop diuretics induce ADH resistance? Answer is yes. Yes, you can write loop diuretics. Yes, they induce ADH resistance. True. Apart from that, there are some crucial concepts that this loop diuretics teach you. What is that? When you give a loop diuretic, when you lose this medullary interstitial hyperosmolarity, remember water cannot be reabsorbed from the descending limb of the loop of Henle, which means the concentrating ability of the nephron is lost. Similarly, the collecting duct's concentrating ability is also lost. At the same time, remember, the diluting ability of the nephron is also lost. So, which means it's not like only the concentrating ability of the nephron is lost, it's also the diluting ability of the nephron that is also lost. When you lose both concentrating ability of the nephron as well as diluting ability of the nephron, which means whatever urine that comes through the from the PCT to the descending limb of the loop of Henle, the same thing will be passed out of the nephron, which means from the descending limb, from the PCT, you know what is the urine that is coming. The PCT usually produces isoosmolar urine, where the urine osmolality will be equal to that of the plasma osmolality. Since the nephron has lost the concentrating ability and they have lost the diluting ability also, here also they lost the concentrating ability, which means they will be passing the same isoosmolar urine. So which means loop diuretics produce isoosmolar urine. Very, very important point. They neither concentrate nor dilute the urine. Clear? Because you lose everything when you give loop diuretics. That is the reason why loop diuretics are considered as very powerful diuretics. It's not just because they are losing the 25% of the sodium. So yes, they are good natriuretics, because I told you loop diuretics, by virtue of this sodium potassium 2 chloride transporter, the physiological capacity under physiological circumstances is 25% of the sodium that is getting absorbed. So yes, when you give loop diuretics, they are going to lose that sodium also. So the urinary sodium will definitely increase in the presence of loop diuretics, which means they are excellent natriuretic agents also. But don't think because of natriuresis, they produce concentrated urine. And similarly, don't think like because they cannot absorb water, they produce dilute urine. They cannot concentrate nor they cannot dilute, which means they are going to pass a isoosmolar urine, where the urine osmolality in the presence of loop diuretics will be equal to plasma osmolality. Which means whenever this happens, I can tell the free water clearance is equal to 0. By the previous derivation we saw some time back, the free water clearance is equal to 0 in the presence of a loop diuretic. Very, very crucial point. So it's not positive, it's not negative, it's equal to 0. That's all. That also answers the question that loop diuretics, why do not produce that much hyponatremia. So loop diuretics incidence of hyponatremia is very, very less. Hyponatremia with loop diuretics is very, very less. Many students believe that loop diuretics produce significant hyponatremia. Actually, that's not the fact. Loop diuretics produce a very little or no hyponatremia. Incidence of severe hyponatremia is extremely rare with loop diuretics. Why? What is the reason? Because they produce isoosmolar urine, which means it's like isotonic loss. We have studied this basics in the previous video itself. Whenever you produce an isotonic loss from the body, your concentration is not going to change, which means solutes, solvents, and all these things are lost in equal concentration. So almost near equal concentration to that of a comparator which you use. So you are not going to produce any change in the serum sodium as much, which means I can write this isotonic losses, total body sodium will be reduced and total body water will also be reduced, and they are excellent natriuretic agents. Alright, among all the diuretics, they are the powerful natriuretic agents. They are very powerful diuretics, but they do not cause hyponatremia because you lose contents in an isoosmolar way. So the serum sodium tends to relatively stable, or only probably a mild decrease will be there, but usually it will be relatively stable sodium most of the time. Remember, this low total body sodium is definitely going to induce hypovolemia in the patient, at least a transient hypovolemia. I'll tell you why loop diuretics do not promote hypovolemia. So this hypovolemia will often be transient only. So there are a lot of reasons for that. If you use loop diuretics for a long time, they will once again become euvolemic after a period of time. So I'll tell you a lot of reasons are there why they produce this euvolemia after a period of time, but only this hypovolemia is going to be transient. Whenever you produce this transient hypovolemia, you are going to cause two things to be activated. One is the RAS system and second is the ADH mechanism. But remember, you might think now ADH will start counteracting the action of loop diuretics and they start producing concentrated urine. No, not at all. I told you ADH needs this medullary interstitial hyperosmolarity. Since there is no medullary interstitial hyperosmolality, even if the ADH levels rise in the presence of loop diuretics, ADH cannot exert their action and the urine continues to be isoosmolar with loop diuretics. They will be isoosmolar. You cannot do anything about that. At the same time, this RAS activation obviously will try to increase the sodium reabsorption. Whenever aldosterone is activated, they try to increase the sodium reabsorption through the channels called epithelial sodium channels. And usually at one point, since the total body sodium itself is less, since the total body sodium itself will become less, and there will be only less total body sodium less sodium that will be filtered in the urine, and already like less sodium is coming, and whatever less sodium that is coming inside, that will be like taken over by this activated ENaC channels, and there will be a point where you cannot lose any more sodium from the body, and the loss will be equal to that of the gain, and you will maintain a constant volume. So you will result in a euvolemic status. So over a period of time, so the equilibrium will be reached. Clear? So only produces transient hypovolemia, but later on they will result in a euvolemic status, courtesy and thanks to the RAS activation, which increases the sodium reabsorption in the distal part of the nephron. But ADH cannot still exert its action because loop diuretics induce a state of ADH resistance, and they are going to continue to produce only isosmolar urine. Without concentration, without dilution, will be equal to that of the plasma. These are very, very crucial concepts again. But remember, loop diuretics are very powerful hypokalemic agents. They tend to produce a good amount of hypokalemia. How? Remember, there are two reasons why loop diuretics produce hypokalemia compared to other diuretic agents. The reason is, one, because of significant RAS activation, the ENaC sodium channels will be activated. We'll be discussing in detail about this. Whenever this epithelial sodium channels are activated, they cause sodium reabsorption. But usually the sodium reabsorption has to be coupled with potassium excretion or potassium secretion, and this is what we call it as caliuresis, and this should happen. Whenever sodium is absorbed in excess in this particular area, it should be always counterbalanced and coupled with potassium secretion. And that's how aldosterone works as well. So how much amount of sodium that is reabsorbed in this area through the ENaC channels and how much amount of potassium that should be secreted in this area is dependent on certain crucial factors. Factor number one is your presence of aldosterone, which means how much aldosterone is there. Because more aldosterone, more activation of ENaC channels. Lesser aldosterone, less activation of ENaC channels. Loop diuretics causes more aldosterone because the extent of volume loss they produce is huge, at least in the initial period. So they activate aldosterone heavily. So loop diuretics produce more sodium reabsorption in this area, so they induce more potassium excretion as well. Second, sodium delivered in this segment, or I can write as delivery of sodium. Delivery of sodium to the distal nephron. So by definition, if you take, loop diuretics are the ones that block absorption of almost 25% under physiological states, I told you. Which means this is substantial actually. 25% is not something less, because under physiological states, the sodium chloride transporter, that is thiazide sensitive channels, absorb only 7 to 10%, and the ENaC channels under physiological states, it's only 3 to 5%. Clear? So 25% of the sodium are going to lose, which means it's really substantial compared to what you see with the other pumps and other transporters. So with loop diuretics, the sodium delivery is going to be huge amount of sodium delivery, because you are not going to absorb this sodium from the thickening lip. All this sodium reaches the distal nephron, and this ENaC channels, seeing so much of flooding of sodium there, they start getting activated so much and they start absorbing so much of sodium, so much of potassium also. So since the delivery of sodium to the distal nephron is more with loop diuretics, because the potassium secretion also will be more, resulting in hypokalemia. Next, urinary flow. So urinary flow. Faster urinary flows obviously result in poor sodium absorption and poor potassium excretion. Slower urinary flows will result in more sodium absorption and more potassium excretion. So these are three things, but loop diuretics is not important for the third mechanism, but loop diuretics are going to produce hypokalemia by first two mechanisms: by activating aldosterone at the RAS system, by inducing hypovolemia transiently. In fact, significant hypovolemia initially. Later on, they'll become euvolemic alright, but initially they'll be having significant hypovolemia. Because of that, they'll activate a lot of aldosterone. Because of that, they can produce hypokalemia. Second, the delivery of sodium to the distal nephron is too much with loop diuretics compared to other diuretics. That is also one reason they produce a significant amount of hypokalemia. So these are some of the principles that you have to note about loop diuretics. Obviously, they are going to produce metabolic alkalosis because they activate RAS as well. So these are the electrolyte effects of loop diuretics. Apart from that, they can produce hypocalcemia, they can produce increased urinary calcium. Long-term usage of loop diuretics can result in nephrocalcinosis or even calcium stones, and they can produce ototoxicity if they are given in massive IV shots. So a lot of stuff are there which we'll discuss in nephrology. But remember, loop diuretics do not produce that much hyponatremia, but they can produce a significant hypokalemia. Fine. Now come to the thiazide diuretics. Why I'm explaining? Yeah, I'm not going to tell anything right now. I'll be explaining this in some time. So what about the thiazide diuretics? Thiazide diuretics are going to affect this transporter here, that is sodium chloride transporter, that is present in the DCT. DCT is the cortex. DCT is present in the cortex only. It's not in the medulla. When you block this, obviously you are going to result in sodium loss. Obviously you are going to result in sodium loss, which means urinary sodium is going to increase here as well, which means they are also going to induce a good amount of natriuresis. Because of that, they induce volume loss. Yes, true. At the same time, since they induce a volume loss, because the total body sodium will be reduced obviously with thiazide diuretics. And because of that, they induce transient hypovolemia initially only, but later on I told you by the same mechanism, it cannot sustain for long because this will trigger RAS, and once RAS is activated and the total body sodium itself is reduced, the filtered sodium itself will be low, and whatever sodium that is filtered, that will be reabsorbed by the hyperactivated RAS. So they will reach a euvolemic state over a period of time. So which means they will reach euvolemic state over a period of time, which means patient will be euvolemic, especially if you take a chronic thiazide. So this RAS activation obviously is going to take up more sodium, try to take up more sodium, but it not completely, match the sodium loss with the thiazides. So they take up more sodium. At the same time, they can lose potassium, because when they take sodium in the distal nephron, they have to lose potassium. So the thiazide diuretics also can produce hypokalemia. Hypokalemia is possible with thiazide diuretics, but it's not significant because hypovolemia induced by thiazide diuretics is not that great, because the sodium lost is not that great. That's why. So RAS activation is not that great like loop diuretics. At the same time, the sodium delivery to the distal nephron is again not that great. It's only 7 to 10% under physiological condition. That much only the sodium chloride transporter is going to absorb the sodium. So that's why hypokalemia is there, but not that significant that of a loop diuretics. But remember, one thing that remains really, really significant for thiazide diuretics, that is the hyponatremia. I mean, whenever you see a case of hyponatremia in a OPD, the patient is on thiazides, we take it as a thiazide-induced hyponatremia unless proved otherwise. It is that significant, thiazides and hyponatremia in our population. So why is it so? If they don't produce that much natriuresis like that of loop diuretics, but still they produce that much severe hyponatremia and very potent hyponatremic agents. How? You have to understand one fact. Thiazides are present in the cortex. I mean, thiazide diuretics act on the pumps that are present in the cortex, which means in no way they are actually affecting the medullary interstitial hyperosmolality. Which means even in the presence of thiazide diuretics, you have intact medullary interstitial hyperosmolality. You are not affecting the hyperosmolality at all. So if you do not affect the medullary interstitial hyperosmolality, what really happens is your hypovolemia will start activating the ADH persistently. Once the ADH levels rise, this ADH will start acting on the distal portions of the nephron. So this ADH will start acting on the distal portion of the nephron. Because the ADH levels are high, they are going to induce a lot of water reabsorption. They are going to induce a lot of water reabsorption as well. At the same time, remember this sodium loss, this natriuresis and this sodium loss and the resultant total body sodium decrease will activate the other transporters in the nephron also. Other transporter in the nephron. Remember, the only significant other transporter in the nephron is the sodium potassium 2-chloride transporter. That will be stimulated as well because of excessive sodium loss. To counteract that, the body tries to adapt to it by activating this other transporters along the nephron. So once the activity of this sodium potassium 2-chloride transporter is enhanced, this NKCC2 pumps action is enhanced, so they are going to produce more and more sodium accumulation in the interstitium, which means you are actually increasing the medullary interstitial hyperosmolality, You're maintaining, not only maintaining, you're actually increasing, but it cannot exceed that 1200 mark. I'm not telling that, but compared to physiology, it actually can even potentiate the medullary interstitial hyperosmolality because of hyperactivation of the sodium potassium 2-chloride transporters. So what I'm trying to tell this, since the medullary interstitial hyperosmolality is more potent and more intact in case of a thiazide diuretic, at the same time ADH is in excess, ADH still can act because there is no loss of medullary interstitial hyperosmolality here. I can tell that they are going to produce relatively more water retention compared to that of the loop diuretics, which means the total body water decrease will not be that great compared to that of the loop diuretics. Clear? Which means they are producing loss of sodium in relation to the water. So there is a mismatch, there is a balance. So that is the reason why the serum sodium drops. Clear? So this mismatch, which means they don't lose that much of water, the reason is because one ADH is in excess, at the same time ADH action is potentiated as well because of the significant medullary interstitial hyperosmolality that is generated because of use of thiazide diuretics. So I can also tell you the fact that thiazide diuretics are going to cause ADH sensitivity also. I mean, not directly, they increase ADH levels, at the same time they increase the medullary interstitial hyperosmolality. Coupled both these things, if you analyze, you can understand the fact that thiazides can potentiate the ADH action, or thiazides improve ADH sensitivity, which means more ADH means lesser water excretion and relatively more water reabsorption. So the mismatch, you lose only sodium, but you don't lose that much of water, result in hyponatremia, significant hyponatremia. That's why one of the important side effects of thiazides, your pharmacology textbooks will give SADH. Even though it's not perfectly correct, thiazides only promote ADH sensitivity, but they do not cause direct release of ADH from the central nervous system. They don't stimulate the pituitary to release ADH. But remember, thiazides cause tremendous ADH sensitivity. Very important point. That is the reason why you get hyponatremia a lot with thiazide diuretics. So what will be the free water clearance here? Here, with the use of thiazide diuretics, actually the urine osmolality will increase rather than decrease, which means it will be more than that of the plasma osmolality most of the time, and they are going to produce a negative free water clearance. So with thiazide diuretics, the free water clearance will be typically negative, not zero. And because the free water clearance is negative with thiazide diuretics, relatively losing more sodium and conserving more water, you result in a hyponatremia. So you have to understand, loop diuretics, zero free water clearance, isotonic urine or isoosmolar urine, whereas thiazide diuretics, hyperosmolar urine, and urine osmolality will be high and a negative free water clearance. And most important fact is these 2 points that are important. Loop diuretics are going to induce ADH resistance, whereas thiazide diuretics are going to induce ADH sensitivity. Very, 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 very important points. Loop diuretics induce ADH resistance, thiazide diuretics induce ADH sensitivity. Never ever forget this fact. Why I am telling this so much and why I want to bother so much for you to make you understand these particular facts? Because I'm going to use loop diuretics in SAADH patients. Because in SAADH, it's like a condition of excess ADH. So loop diuretics induce a state of ADH resistance. Even in the presence of excess ADH, in the presence of loop diuretics, ADH cannot act. That's why I can use loop diuretics in a patient with SAADH. At the same time, I can use thiazide diuretics in diabetes insipidus. Because in diabetes insipidus, a condition like poor ADH action, especially for nephrogenic diabetes insipidus, we prefer this thiazide diuretics. Because in nephrogenic diabetes insipidus, there will be ADH resistance of the kidneys to ADH. So thiazides improve that resistance and increase the sensitivity to ADH, of the nephron to ADH. So thiazides can be used in nephrogenic diabetes insipidus. And loop diuretics can be used in SAADH. Whenever I talk to the students, they get bamboozled by the fact that loop diuretics can be used in SAADH, because SAADH is a condition where you get hyponatremia, and they will be like, are you kidding? You can use loop diuretic in a patient with hyponatremia, SAADH already. Yes, you can, because the principles are the same. So if you understand the core principles, you can tell all this very, very easily. Clear? So that's the idea. Fine. So understand medicine in a very different way. So that's what I wanted to tell. So now let us move on to the next topic, that is what are the factors that cause the ADH to act and the ADH to get released, and what are the facts that is going to determine how much ADH to be released, and what is going to be the thirst mechanism, how the body generates and regulates this osmolar status. For that, we have to understand one important diagram about the circumventricular organs. So let me tell these are the circumventricular organs. You have to know these things first. So what do you mean by circumventricular organs? These organs are located outside the blood-brain barrier, which means they are not bound by the blood-brain barrier, which means they can sample the normal plasma constituents itself. So in this, our topic of concern will be these two. This is organ vasculosum of lamina terminalis. That's what we call organ vasculosum of lamina terminalis. Then you have subfornicial organ. So it's below the fornix. This is FX fornix. It's below the fornix. So this is subfornicial organ. Then you have a lot of other areas that is not of that much importance for us. This is the choroid plexus, and this is the pineal gland, and this is the subcommissural organ, and you have your median eminence of the hypothalamus. Then you have neurohypophysis, posterior pituitary, and you have area postrema. You know, this is the area that is closer to the chemotactic trigger zone and induced vomiting, area postrema. So these are the important circumventricular organs, of which our concern right now is on the organ vasculosum and the subfornicial organ. Because these two organs are very, very important, because they sense one important entity called osmolarity, plasma osmolarity, because they have this osmoreceptors. Apart from that, they can sense angiotensin 2, they can sense that volume status, they can sense antibodies, cytokines, lot of things they can sense, but our topic of concern is about the posterior pituitary and the osmolar status. So let us keep it very simple, and they have osmoreceptors. These osmoreceptors are going to sense the serum or plasma osmolarity. So whenever osmolarity is low or osmolarity is high in the plasma, they are going to get, appropriately activated, and they will give stimulus to the hypothalamus. So let us assume osmolarity is increased. So in this setting, let us assume they will get activated, and they are going to give signal to the hypothalamus, and this hypothalamus now gets activated, and they are going to release ADH through the through the posterior pituitary into the circulation. So this is what is going to happen. So that is why this concept is very important. At the same time, this subfornicial organ is also going to activate hypothalamus to trigger thirst principle. So to take more water and ask the patient take more water. So that is also done by the subfornicial organ. So basically what they have is the osmoreceptors. That's what I want to tell. That's the take home point. So now let us see in a little detail about how these mechanisms and how these things are going to work. First, let me draw the pituitary. So, and you have the hypothalamus here, and you have the circumventricular organs here. So let me duplicate this and keep it aside, because I'm going to discuss about one more disorder also, which is very important for the current topic. Now let us assume, and let us give a hypothetical scenario where a person is playing in the sun without drinking water. Whenever you play in the sun, you don't drink water, and you're playing very happily, and after some time, a lot of water is evaporating from your body, and you're not replacing it. And through sweating also you're losing water. And through insensible water loss, again you're losing a lot of water, because the heat is more, and insensible water loss will increase in the presence of more heat. So that is going to definitely concentrate the blood, and they're going to increase the serum osmolality, or plasma osmolality, you can call it in any way. So this excessive serum osmolality obviously gives feedback to the circumventricular organs, and they will be sensed, and they're going to trigger, let us assume, the circumventricular organs. And this is going to give stimulus to the hypothalamus, and hypothalamus reacts to it by causing excessive ADH release. At the same time, they promote activation of thirst by activating the thirst center. These are the two crucial elements against the development of hyperosmolarity. So now what thirst is going to do? Thirst is going to make the patient thirsty and they are going to take more free water intake. So why they take more free water intake? Because this is to neutralize this serum osmolarity. That is to neutralize the excessive serum osmolarity. To neutralize that, this thirst is there. Because of that, you take more water intake, free water. And what ADH is going to do? ADH is going to act on the kidneys in the distal part of the nephron, in the collecting duct, and they're going to cause excessive water reabsorption. So this excessive water absorption, once again the reason is to neutralize this excessive serum osmolarity. There are two principles that are acting side by side to neutralize this serum osmolarity, higher serum osmolarity, that is thirst causing more water intake, and ADH principle causing excessive water reabsorption. That is very, very important, because then only you can actually normalize this increased serum osmolarity. So this is like a feedback. This is a perfectly beautiful loop that is working in a near perfect way to keep the serum osmolarity in the normal range. And you have to also understand that the circumventricular organs have a set serum osmolarity, like above which ADH will be released for sure. So that is what we refer to as an osmostat. Osmostat means for each and every particular person, you'll have a different osmostat, but not widely varying. So maybe 270, 280. At a particular set point, you will release this much amount of ADH. So that is what we refer to as an osmostat. They have a threshold for release of ADH. That's what I want to tell. So next. So what is happening to the urine? Because you are reabsorbing more and more water in the presence of ADH action, your urine will have less water, which means your urinary concentration will increase, which means you are producing a urine with higher osmolarity. So that is the reason when you play from the sun and pee, what will be the urine color? It will be high colored, because you are concentrating the urine. Simple. But understand the fact, there is one important relationship that is happening here. So you can see whenever the serum osmolarity is increased, because of some reason, the urine osmolarity is also increasing, which means both arrows are moving in the same direction. If serum osmolarity decreases, urine osmolarity also will decrease. Which means there is some linear relationship between these two. So let me tell you that. So if I plot in a graph, you will understand it better. So I can write serum osmolarity here, which is increasing in this direction, and I can write urine osmolarity here, which is actually increasing in this direction. So if you plot the serum osmolarity and urine osmolarity, the graph is going to behave something like this. Which means whenever serum osmolarity increases, the urine osmolarity also increases. Whenever serum osmolarity decreases, the urine osmolarity also will decrease. So they have some linear kind of relationship between them. And who is coupling this urine osmolarity with the serum osmolarity? It's the ADH. ADH is the one that is maintaining this linear relationship, which means whenever serum osmolarity increases, ADH also increases. Whenever serum osmolarity decreases, ADH also decreases. So ADH is the one that maintains this relationship between serum osmolarity and the urine osmolarity. Whenever you don't have a good relationship between serum osmolarity and urine osmolarity, you can think of ADH problem, not absolutely due to ADH problem, but you can think about ADH issues. Because then only, if you don't have a linear relationship, when one is increasing, other is decreasing, and one is decreasing, other is increasing, you can think that it is not possible. Clear? So there is a problem with ADH. So that's what you think about. So in the presence of ADH, they should have a linear relationship only. Now let us move on to the disease. That's why I put two diagrams. So now you can understand about disease called SAADH. So, but it's inappropriate to call SAADH. I can simply call it as SAAD. That's the more appropriate term. That is syndrome of inappropriate antidiuresis. You have to understand SAADH means it's not only due to excessive ADH. It's due to a lot of other things that can mimic conditions that have excess ADH. So you can call it just a syndrome of inappropriate antidiuresis. So what is the problem in SAADH? So the problem in SAADH is the circumventricular organs or the hypothalamus, they are not going to respond to the serum osmolarity due to some reason, and they are going to produce excessive ADH by default, and their sensing mechanism is lost. So this is a very simplified scenario. So don't think this is the only scenario. There are a lot of similar scenarios like this. That will be explained when I'm going to discuss about the types of SAADH. But right now understand it's very simple scenario. They don't respond to the serum osmolality and they are releasing ADH irrespective of what is the serum osmolality. So this excess ADH, obviously you know what they're going to do. They're going to go to the distal part of the nephron and the collecting duct and they're going to cause excessive water reabsorption. So this increased water reabsorption definitely will make the blood dilute. So in very simplified terms, I can write it as a dilute blood. Dilute blood means you are going to reduce the serum osmolality, which indirectly means I'm adding more water to the whiskey, which means my serum sodium is also going to reduce. I'm going to result in a hyponatremia and hypoosmolar state. Now, what will happen to the urine? Now in the urine, obviously you know the water content is going to be less, because of that the urine osmolality will be very high and the urine will be highly concentrated. And what you are actually seeing here is the arrows are opposite. I told you there should be a linear relationship for serum osmolality and urine osmolality. Here the arrows are opposite, which means there is some problem, likely to be ADH problem. Then only the arrows can behave erratically like this. And this low serum osmolality, you can ask me, won't it suppress the circumventricular organs and the hypothalamus? No, that is a problem here, because they do not respond to this low serum osmolality and suppress the ADH release. They keep on secreting ADH irrespective of what is the serum osmolality. That's the problem here. And one more point I want to tell you is, the urine osmolality will become actually fixed. For one particular patient with SAADH, he will have a particular fixed urine osmolality, which means they will be excreting urine and they will be excreting solutes and they will produce concentrated urine only at that particular osmolality. And it will be higher than the serum osmolality, obviously. But they will be producing a fixed urine osmolality. That's very important point about SAADH again. Fine. And next, urine sodium will be high in these patients. You have to answer this. Why urine sodium is high in these patients? Actually, this urinary sodium that is high is actually like an artifact. Because if you take 24-hour urine sodium, that will be usually equal to that of the sodium intake by the patient. Which means, what I'm trying to tell is, the sodium output from the urine is equal to the sodium intake. So that is the reason why these patients are in euvolemic state. Even though you can explain anyway, but this is the main reason why these patients are in euvolemic state, which means there is no net change in the sodium balance in the body. Remember, when sodium intake is more compared to the output, you will result in hypervolemic state. When sodium intake is less compared to the loss happening in the body, you will result in a hypovolemic state. But if sodium intake is equal to output, you will obviously result in a euvolemic state only, and that is what is happening in SAADH. Your sodium intake is equal to the net output. But why the serum sodium, urinary sodium is appeared to have increased? That is because these are spot values. Spot values, that's what, if you take the SAADH criteria, they are told spot urinary sodium of more than 40 millimoles per liter. So that's a spot value. Definitely it will be increased, because the urine is concentrated and in less amount of urine, you are having more solutes. That's why it's appearing as if it's increased. But there are some mechanisms that are going to increase the urinary sodium also, given by many standard textbooks. For example, if you ask the equation ADH, SAADH, what is the equation in SAADH? Total body sodium by total body water. Here you know the total body water is going to increase. Because of that, your serum sodium is decreasing. That is mainly because of the diluting effect of the water. Here I told you the total body sodium is normal because the intake is equal to output. So there is no change in the total body sodium. The water is the one that is the culprit, and water is the one that is diluting the serum and producing hyponatremia. So that is why you get a euvolemic hyponatremia. So there are a lot of theories behind this. There are two questions you have to answer. The first question I asked is, why the urinary sodium is increased and what are the other theories behind it? I told you the concept behind it, but what are the other theories behind it? First question to answer. And second question to answer is, this excess water in the body, where they are. I mean, you are calling euvolemic, all right, but it's confusing me. Many students ask me where that excess water is going in the body. It's there in the body, but where is there? I couldn't see that. So by definition, SAADH patients must be euvolemic, means they should have normal BP, they should have normal JVP, and they should not have any evidence of postural hypotension, because postural hypotension means that the patient is having hypovolemia. So they should not have any postural hypotension, and postural hypotension means they are having salt loss. Only salt wasting states will have this hypovolemia and postal hypotension. Here, where there is salt loss, intake is equal to output. That's why you should not diagnose SAIDs in the presence of postal hypotension or hypotension or hypertension. No, don't diagnose. Next, patient should have no edema anywhere, and patient should have no ascites and no effusion, no pleural effusion. No ascites or effusions. Very, very important point. Why this? But in the presence of excess water, where is that excess water? And I couldn't see that, and that's what your question is. So let us go back to our initial base, that is total body water is divided into ICF and ECF. ECF is divided into interstitial fluid and the plasma. So interstitial fluids, one other important compartment, that's a sub-compartment that is called a transcellular compartment where you have body fluids. Fine? So simple, easy to understand. So whenever you take more water or ingest more water, alright, or when you give more water IV, whatever may be the route, first route of entry of water into the body, where? It is a plasma. That's the first place where the whatever water you give to the system, the first place where it enters is the plasma. So remember, this plasma is a component of extracellular fluid. And in order for this extracellular fluid to retain this plasma, retain this water in the ECF itself, they need this sodium, which means the sodium should be high in the ECF, which means the total body sodium should be high. Then only the ECF sodium will be high, then only they can retain this excess water. And they cannot retain this excess water if there is no sodium, because sodium is the one that holds the water. It's like a attractor of water. So if you don't have this osmol to hold the water, which means if the total body sodium and the ECF sodium is normal, obviously whatever water you add into the system will be moving into the ICF only. The ICF only will take up all this water, which means it comes through the plasma, which means there will be a transient expansion of the blood volume will be there. Yes, definitely there will be there. The transient expansion while the time of absorbing this excess water that is going into the plasma, that transiently expands the plasma volume. But definitely that will enter into the ECF very soon, very fast. And yes, you are asking, how can I believe? When the patient is not having edema, patient is not having ascites, when the patient is not having any features suggestive of hyperolemia or volume overload, how can I believe that the water is entering the ICF only? Yes, you have to believe, which means SAIDH patients' body weight will be high. That's the evidence that this fluid is in the ICF. Which means a patient who's 60 kilogram in weight, admitted to the hospital, hospitalized, and develops SAIDH. And after SAIDH, his weight might become 66 kilogram. If he gets that 66 kilogram, what does it mean? This excess 6 kilogram that he has gained is the one that is excess total body water he is having. That is the increased total body water, which means all these are actually locked in the plasma and the ICF only. So plasma initially it will expand and it is going into the ICF. So plasma is expanding initially and ICF is expanding. So this excess water is in the plasma and the ICF only. Clear? So that is the idea. But it doesn't stay in the plasma. So you cannot tell excess JVP or excess BP or not. At the same time, remember, this fluid is not entering the transcellular fluid or interstitial fluid compartment. They can retain in those places only if you have a sodium. If you don't have sodium, you cannot retain them. So that is also the main reason why if there is no interstitial fluid excess, you will not get edema. If you don't get this excess transcellular fluid, there will be no third space collection, like there will be no effusion or no ascites. Similarly, it's not going to stay in the plasma also. Even though you might get this transient expansion of the plasma, you might again argue with me telling that JVP should be elevated because there is transient elevation of plasma volume. And you might argue the transient hypertension must be there. But they don't get. They'll have normal BP and normal JVP only. Why? This transient expansion of blood volume will activate the natriuretic peptides released from the heart. Will activate the release of natriuretic peptides. Because they activate the release of natriuretic peptides, they will cause a little slight natriuresis, but remember, this is not a disproportionate natriuresis. This is a proportionate natriuresis to what you take. That's all. And again, this is not a disproportionate natriuresis. Be very, very careful. This natriuresis is happening to remove this water out of the system. This in way it is protective, but to remove this water out of the system. That is the reason why this natriuresis is happening. So which means they will not allow this natriuretic mechanism will not allow the water to expand the plasma, and which means the plasma volume ultimately will be normal only, and this water is moving into the ICF, and that is evident by increasing body weight. So that is the reason why body weight measurement in SAIDH is really important, because when I give this treatment to SAIDH, my goal is to achieve a normal body weight once again, 60 kg, which means patient will look heavier than before and appear heavier than before. That is because of the excess water in the body, and I have to remove that excess water with treatment for SAIDH. Very, very simple. That's all. So you can now understand one fact. This natriuresis is also one reason why your urinary sodium is a bit high in SAIDH. This is what the textbooks will give, but ideally speaking, this is spot sodium. So it will be high because of the concentrating effect of ADH. But the net intake must be equal to the net output of the sodium. Then only you will maintain the patient eulemic state. Very, very important concept. That should be there. And what about the thirst in SAIDH? Hope you understand this. What about the thirst in SAIDH? Thirst is again suppressed in SAIDH. Why? Because I told you this low serum osmolality cannot have any impact on the ADH, but still this low serum osmolality can act through the circumventricular organs and hypothalamus, because the thirst center is still responsive. Only the ADH mechanisms are short here, but the thirst centers are still responsive, which means the patient will have reduced thirst in response to this low serum osmolality, which means thirst will be suppressed. And this is another crucial concept to understand. I am telling that this suppression of thirst is a very, very important protective mechanism for development of serious hyponatremia in SAIDH. Why it is protective? And usually they won't allow development of serious hyponatremia. And again, this hyponatremia in SAIDH patients is just due to the transient expansion of the plasma volume. And that is the main reason why they develop hyponatremia. Until they go into the ICF, they develop that hyponatremia. But understand the fact that the suppression of thirst is a very important and protective mechanism for development of significant hyponatremias. Why? Because you know the problem in SAIDH is more absorption of water from the kidneys. But where this water is coming from? This water can be filtered only if you take sufficient water. Only if you take water, you will filter this excess water in the plasma. In the kidney. So suppose if you don't take sufficient water at all, if the intake is very poor, if you reduce your fluid intake or if you reduce your water intake, obviously your reabsorption cannot be happening beyond a point. So that will come to a halt, and all these things will come to equilibrium and will maintain at a particular sodium level. So that is why this suppression of thirst is a very important protective mechanism for against development of serious hyponatremias in SAIDH patients. Very, very important point again. Because in hypothalamus, the ADH releasing mechanism and the thirst inducing mechanism are mutually exclusive. They are happening in different areas. So if one is damaged, other will come as a protection. So if there is problem in thirst, ADH will come as a protection. If ADH is having some problem, thirst will come as a protection. So this loss of thirst is a very important protective mechanism. Then why do the patients develop SAIDH? Which means why do the patient develop hyponatremia in SAIDH? That's what I'm asking. That's because of two important reasons. One, patient sometimes may not regulate their water intake properly. They might be thinking that they are drinking less, even though they don't have a thirst. They might try to drink more because they are not drinking sufficient water. So that might create some, issues in the patient's mind so that they drink more water. Actually, they don't have thirst. Next principle is the fact that most of these SAIDH are hydrogenically induced, which means patient will not drink, but the water will come into the patient's body by virtue of doctor's treatment, which means the doctor can infuse a lot of normal saline and water containing fluids. Because of that, the patient may develop more and more worsening hyponatremia. So that's what you have to understand. SAIDH is the most common cause of hyponatremia in hospitalized patients. Most often it will be hydrogenically induced. Severe hyponatremias in SAIDH are most often hydrogenically induced. So after understanding all these concepts, let us move on to actual etiologies of SAIDH. But before going to the etiologies of SAIDH, please understand the fact that SADH is the most common cause of hyponatremia in hospitalized patients. Why? Two reasons. One, I told you SADH most of the time is the hyponatremia in SADH is iatrogenically induced. And second reason, SADH can happen literally in any sick patient. Why? ADH is a stress hormone. I mean, in any stress, ADH will be released. So hospitalization and sick state itself is a stressful state. That is why ADH may be released in excess, and probably that is the reason why SADH is extremely common in the sick patients, and any sickness can produce SADH. And these two reasons are the reasons for the first point I told you, that is SADH is the most common cause of hyponatremia in hospitalized patients. Fine. Sick patients have SADH, and this will be causing hyponatremia only mild most of the time, and that will be worsened by the doctor iatrogenically by giving more fluids unnecessarily. So this is the loop. So let us see the etiology now. What are the etiologies of SADH? Usually I tend to give by a mnemonic called MAD CHOP. That's the mnemonic. What do you mean by MAD CHOP? M stands for malignancy. M stands for malignancy, very, very important. Malignancy-related SADH usually happens in a very important cancer called small cell lung cancer. This is the most important cancer as far as I know, because it's multiple times asked question, small cell lung cancer. See, usually malignancy-related SADH means it's a paraneoplastic syndrome. And remember the fact that the most common paraneoplastic syndrome in a patient with small cell lung cancer is SADH. Very important. They secrete ADH. Second, it can happen with other cancers like thymoma, lymphoma, and even gastrointestinal adenocarcinomas. So even though this is an MLE mnemonic, this MAD CHOP, I usually use this mnemonic. I use the mnemonic called MD CHOP only, but no issues. So A stands for ADH, that is secreted ectopic, and again this points towards malignancy only. So I'm not very happy about this A. So you can remove this A also, and you can form the mnemonic like MD CHOP. So you can add and form MAD CHOP also. So D stands for drugs. Obviously, there are a lot of drugs that can produce SADH. What are the drugs? It can start from anti-epileptic drugs. Most important anti-epileptic drug that you should ever know is carbamazepine. I told you before itself in the previous video about the basics of the posterior pituitary and in the beginning, that carbamazepine is one important drug that can be even used as a treatment for diabetes insipidus where there is low ADH, because it's such a powerful trigger for ADH release from the brain, from the pituitary. So that's why carbamazepine can produce SADH, one of the very important drugs, and its congener oxcarbazepine can also produce SADH. Apart from that, valproic acid, that is valproate, can also produce SADH. Then a lot of other drugs, antidepressants, can produce, especially SSRIs. I don't know why the MLE people like this SSRIs. This is an MLE favorite, especially this drug called fluoxetine. If they give a patient comes with hyponatremia, patient is on antidepressant, it is for granted the patient is having SADH because of fluoxetine MLE. These are stereotypical questions, very common. Then you can get with anti-cancer drugs. What are the anti-cancer drugs? Most important in this group is the cyclophosphamide. Apart from that, it can happen with cisplatin, oxaliplatin, platinum compounds. It can even happen with vincristine, zinc alkaloids, vincristine, and all these drugs. It can happen with anti-diabetic drugs, but only older anti-diabetic drugs like chlorpropamide can produce, but the modern drugs usually does not produce this SADH. Apart from that, there are a lot of other drugs that can produce SADH, like thiazides. Thiazides produce SADH by different mechanisms. They potentiate the ADH action. We studied in the same video some time back. And you can get with nicotine. You can, this and all I think I've told you in the previous video itself. You can get with IVIG, intravenous immunoglobulin. You can get with a drug called MDMA, that's otherwise referred to as ecstasy. It's a rave drug. It's a party drug, MDMA, ecstasy. And you can get with clofibrate. This is a panned fibric acid derivative for hypertriglyceridemia, if you don't use it anymore, clofibrate. So these are some of the other drugs that can produce. And you can get with some antipsychotic drug also, like haloperidol and flufenazine. haloperidol and flufenazine. So these are some of the drugs that produce SADH, but among all these, the most important are these four. That's all. Suppose if somebody asks you what are the drugs you will remember for exams, only these four you have to remember. At least this is the least minimum criteria for exams. SSRIs, then cyclophosphamide, thiazides, carbazepine. Don't forget this. Okay. Now, what are the mechanisms that they produce SADH? So let us see this carbamazepine and oxcarbazepine, then probably this vincristine. Where is that? Yeah, vincristine. Then this chlorpropamide and clofibrid and nicotine. So all these things are going to produce SADH by increasing the ADH release. Unknown mechanisms, but I mean in the sense how they do that is unknown, but they increase the ADH release. This carbamazepine, oxcarbazepine, then vincristine, chlorpropamide, nicotine, all these things are natural, things that naturally increase the ADH release from the pituitary. Then there are some things that potentiate the ADH action. What are things? Whenever I tell about potentiating ADH action, the first thing that should come into your mind is thiazide diuretics. They are going to potentiate the ADH action. Then cyclophosphamide, potentiate ADH action. Then, yes, so these are the conditions, these are the agents. Even chlorpropamide also can potentiate. It can happen by multiple mechanisms. These are the agents that potentiate the ADH action. Then I can tell agents that act by unknown mechanisms. For example, haloperidol, flufenazine, IVIG, MDMA, cisplatin, all these things are going to act by unknown mechanism of action. How they produce SADH itself, we don't know. Fine. So this is something not so important, but still I just want to complete. So that's why I told you that. And here C stands for CNS disease. So what are the CNS disease that can produce SADH? A lot of CNS disease, right from meningitis to encephalitis or meningoencephalitis, brain abscess, Guillain-Barré syndrome, acute intermittent porphyria, all these things are important CNS causes. In this, the most important will be GBS, the most important. Second important will be acute intermittent porphyria. You know, acute intermittent porphyria is due to deficiency of an enzyme called porphobilinogen deaminase, that's called PBG deaminase, where you will be having excessive levels of porphobilinogen. We have studied in detail in hematology section. So it is a triad. What is the triad of acute intermittent porphyria? Do you remember? The patient will be having abdominal pain that is severe most of the time, and patient will have neuropsychiatric problems like quadriparesis or weakness, depression, psychosis, neuropsychiatric complications, and patient will have dark urine during the time of acute attack. Apart from that, one adjunctive thing that's usually going to happen in this acute intermittent porphyria patients is SADH and hyponatremia. You have to remember. This is a triad of acute intermittent porphyria and hyponatremia, don't forget. So these two are important for exams as well. Then H stands for hormone deficiencies, hormonal problems. What hormone problems can result in SADH or can mimic SADH like picture? Two hormone deficiencies. One is thyroid hormone deficiency, that is hypothyroidism. So in hypothyroidism, we don't know the mechanism of action. They mimic SADH like picture. And second is hypocortisolism. Low cortisol can produce SADH. Very important in secondary adrenal insufficiency. Not important for primary adrenal insufficiency, where the hyponatremia will be due to salt wasting. But secondary adrenal insufficiency is the one that's going to cause typically SADH like hyponatremia. So we don't know the mechanism of action of hypothyroidism, but we very well know the mechanism of action of how low cortisol can produce SADH. How? So that comes from the understanding of the V3 receptors, mechanism of action of ADH. So whenever ADH is there, you know there are V1, V2, V3 receptors. V3 is otherwise called as V1B receptors. So we can write ADH can act on V1B or V3 receptors, and they're going to induce ACTH release. Once they induce ACTH release, they are going to produce excess cortisol, and this excess cortisol is a very important negative feedback regulator for ADH itself. Suppose when you don't have this cortisol, you will lose this negative feedback, which means you are going to increase the ADH release. As simple as that. This is the reason how low cortisol or hypocortisolism in secondary adrenal insufficiency can produce SADH. Alright. O stands for others. Others means here I want to talk only about HIV. And finally, you have P, P stands for pulmonary causes. That's very, very important. Again, the most important pulmonary cause is pneumonia. Pneumonia is the most important. In particular, in exam, they will inquire about this Legionella pneumonia. I mean, why in Legionella pneumonia? What is the triad of findings in Legionella pneumonia? So remember, usually Legionella pneumonia's triad is interstitial pneumonia, that is atypical pneumonia. They will produce interstitial nephritis, that is due to allergic type of interstitial nephritis, kidney injury, and third is hyponatremia, very important part of the triad. Apart from that, they can produce other problems like initial GI prodrome will be there in many Legionella pneumonia patients. So that is the reason why they ask that Legionella is an important cause of SAIDH. The reason for Legionella-induced hyponatremia is SAIDH. If they give atypical pneumonia with kidney injury, and if they give hyponatremia, if they ask you what is the cause, answer it is Legionella, because they produce SAIDH. Then apart from that, TB can produce positive pressure ventilation. You give NIPPV or IPPV. Positive pressure ventilation can produce, and asthma can produce, cystic fibrosis can produce, but these are not important. The pneumonia is the most important, especially Legionella pneumonia. So I have told you so many causes about SAIDH, but what are the things that you have to remember? Small cell lung cancer, thymoma, carbamazepine, SSRIs, cyclophosphamide thiazides, then hypothyroidism and hypocortisolism, definitely yes, Legionella pneumonia, that's all. If you don't have time for the exams, just remember these causes and move on, that's all. Usually question will be from one of these only. So these are the etiology of SAIDH. Then you have some types of SAIDH as well. So what are the types of SAIDH? You have 5 different types. One is called A, B, C, D and E. What are these different types of SAIDH, A, B, C, D and D? So for this, again, let us visit back to the pituitary and the circumventricular organs and the hypothalamus, hypo-T. So they are going to produce ADH, and this ADH is going to act on the V2 receptors in the kidney, causing water reabsorption. Fine. So the problem is going to be one among these areas in the axis only. So first let us see this type C and type C. Type C and type C, they do not respond to serum osmolality. Even though in SAIDs the patients will have low serum osmolality, they are not going to respond to this low serum osmolality, and ADH will be produced irrespective of the serum osmolality. That is the problem in type A and C. So if this increased ADH is erratic, that is called type A. If this increased ADH is continuous, that will be type C. Remember, this increased ADH can even come from ectopic source also. Usually whenever it comes from ectopic source, it will be usually continuous. Ectopic means always it's from a cancer as a part of paraneoplastic syndrome. Need not come necessarily from the pituitary. So increased ADH, erratic, not responding to serum osmolality. If it's erratic, you call type A. If it's continuous in release, it is called type C. That's all. What about type D? Type D, you will have this gain of function mutation of vasopressin 2 receptors, which means they are hyperactive now. Which means even with low ADH, they are going to reabsorb more and more water and mimic an ADH, SADH-like picture. So this is what we refer to as type D SADH. Then you have only 2 types, that is B and E. So B stands for something called reset osmostat. That's called a reset osmostat. So what do you mean by reset osmostat? It's very simple. It's not like excess ADH, but these patients' osmolar status itself will be lowered, which means the threshold for sensing the osmolality will be low. For example, if my circumventricular organs and hypothalamus senses and keeps the threshold of release of ADH at maybe 280, let us assume 280, 285, that is the threshold for release of ADH according to my hypothalamus and my circumventricular organs. In patients who are having reset osmostat, the threshold will be much lower, maybe 250 or 255. So they're going to set a lower threshold for release of ADH, which means the moment the osmolality crosses the threshold, the 250 or 255, it is low for us, but that is what is happening in those patients. It crosses the 250, 255 mark, ADH will be released, and they will be bringing the serum osmolality back to 250 or 255, which means that will approximate to the sodium of 125 or 128, which is hyponatremia for us when we look from outside compared to the normal patients. But for their body, it's supposed to be normal for their brain at least. They're going to maintain only at that sodium range, and they're going to maintain only at that particular osmolarity. And remember, this is usually mild. Reset osmotat patients generally tend to have a mild hyponatremia and mild lowering of serum osmolality, and it's generally a benign condition. No matter what you do, I mean, if you give treatment, it might increase, but once again, if you stop the treatment, it will come back to the set threshold because the threshold is completely different. That's why. That's what we call the reset osmostat, where the threshold for sensing serum osmolality is actually lowered. Threshold for ADH release is decreased. That's the idea. Then you have only one type, that is type E. So what do you mean by type E? It is called as baroreceptor reset or baro reset. So what do you mean by this baro reset? For that, you have to understand one important trigger for release of this ADH is low volume status, hypovolemia. The low volume status is very important trigger for release of ADH as well. So who's going to mediate this mechanism? This mechanism is mediated by the baroreceptors. The baroreceptors are the ones that mediate this, causing excessive ADH release from the pituitary whenever the hypovolemic state is encountered or low volume state is encountered. So what if the baroreceptors threshold is low? Which means here the low volume has a threshold. For each and every person's body, this low volume will have a threshold. What if the baroreceptors set a lower volume as a threshold, which means much lower than the normal population, which means the volume, which is normal for most of us, that person's baroreceptors will think that volume is actually hypervolemic or hypovolemic. So because of this principle, even small changes in the volume will result in massive ADH release. So even small decline in the volume, that baroreceptors will think, I'm having so much of low volume, and they will start releasing excessive ADH. So that is the reason why this is what we refer to as type E is referred to as something called a baroreceptor reset, which means the threshold for sensing this volume in the baroreceptors is something erratic here, and they will sense even a small hypovolemia as major hypovolemia, and they will give a big trigger to the pituitary to release ADH. So again, we'll recap what are the types of SAADH. A and C, they don't respond to serum osmolality. They release ADH irrespective of serum osmolality, and A is erratic, C is continuous. That's all. So you can remember C stands for continuous, C for C, tit for tat. And D means mutation in the V2 receptors in the kidney, gain of function mutations. B is reset osmostat. That is the threshold for sensing osmolality, and threshold for release of ADH is actually happening at a lower osmolar plasma osmolality. That's all. And E is baroreceptor reset, where the threshold for volume detection is problem here. So at small decrease in volume also, they will release massive ADH from the pituitary. So this is what we call baroreceptor reset. So these are the things that you have to know. These are the types of SAADH. Then you have to know about the clinical features of SAADH as well. So it's not worth knowing the clinical features, because clinical features means we have seen already enough about the clinical features. They are going to produce hyponatremia only, and you are going to have a euvolemic hyponatremia. That's all. Euvolemic hyponatremia. So this euvolemia is a very, very important word to know. This is a euvolemic hyponatremia. But how will you suspect SAADH in exam? Remember, any patient who is hospitalized, point number 1, they are having hyponatremia, point number 2, and they are having euvolemia clinically, point number 3, which means no hypertension, normal BP, normal JVP, no ascites, no edema, no pleural effusion, and no postural hypotension, which means the patient is euvolemic, clinically at least. Then plus or minus the patient is having, the examiner will give the patient is having higher urine osmolality, plus or minus lower serum osmolality. So if this is the case, at least if you see these 3 things, this is more than enough to tell that the patient is having SAADH only, because SAADH is the most common cause of hyponatremia in hospitalized patients. That's why. Now, we have to see it in a form of criteria, because this criteria is important to understand. That is called the Bartter and Schwartz criteria. What is Bartter and Schwartz criteria? Number 1, patient should have hyposmolar hyponatremia, which means low serum osmolality coupled with low serum sodium. So which means patient should have a hypoosmolar hyponatremia. We have not discussed about hyponatremia segment yet. That's why you are not understanding what is hypoosmolar, normosmolar, hyperosmolar. Hypoosmolar hyponatremia is a true hyponatremia. We'll discuss in some time in the next video. So it's a hypoosmolar hyponatremia, which means by definition the patient's serum osmolality will be less than 275 milliosmoles per kilogram, and patient's sodium will be less than 136 milliequivalents per liter. So hypoosmolar hyponatremia. Point number 2. Patient should be clinically euvolemic. I have told you multiple times, euvolemic patients only can be diagnosed as SAIDH. If the patient is not euvolemic, do not diagnose SAIDH. It's wrong. Number 3, the urine osmolality should be at least more than 100 milliosmoles per kilogram, which means I am telling the urine is at least decently concentrated. With the dilute urine less than 100, you cannot diagnose SAIDH, which means SAIDH means the urine should be concentrated only. Number 4, urinary sodium is increased, which means urinary sodium more than 40 milliequivalents per liter or 40 millimoles per liter, plus the patient should have normal dietary sodium intake. So if you restrict the dietary sodium, then patient may have urinary sodium of less than 40, because I told you in SAIDs the intake is equal to output. If you reduce the intake, output also will be reduced. That's how they maintain euvolemia. So don't restrict the dietary sodium. So in the presence of normal dietary sodium intake, the urinary sodium will be more than 40 milliequivalents per liter. Number 5, patient should have normal renal, cardiac, thyroid and adrenal function. Thyroid and adrenal function. So these are again important prerequisites. Patient should not have organ damage, because if the patient is not having normal renal function, the urinary sodium may be high, but urine osmolality will not be high. Urine osmolality will be isotonic only to that of the plasma if the patient is having advanced renal failure, but I'm not telling. But still it will confirm your diagnosis. That's why patient would have a normal renal function. And why the normal thyroid and normal adrenal? Because hypothyroidism can mimic SAIDH, I told you, and hypocortisolism itself can produce SAIDH. So some authors do not call this as SAIDH, that's why. So this is the 5th point. Number 6, patient should not be on any diuretic agents. No diuretics, because diuretics itself increase the urine sodium, and thiazides, you know, they are going to increase urine osmolality and urine sodium as well, which can mimic SAIDH. And thiazide itself can increase ADH sensitivity and can produce SAIDH like picture. That's why patient should not be on any diuretics, at least for the last 1 week. The last 1 week they should not take any diuretics. Number 7, patient should not have other electrolyte imbalances. Other electrolyte imbalances, here the most important electrolyte is the potassium. There should be no hypokalemia. By definition, potassium should be more than 3.2 at least here. And patient should have no other acid-base disorders. No acid-base disorder, which means SAIDH is a pure water problem. Because of that, it's a pure hyponatremic disorder. You don't have any other problem. That's what I'm trying to tell. No acid-base disorders. So you can see again, I'm trying to prove the same. Here the patient is having high urinary sodium with high urine osmolality with low serum sodium and low serum osmolality. Again, I'm proving the mismatch here, plus other criteria I have explained. That's all. There are some additional criteria there. Additional, or these are supportive criteria. What are the supportive criteria? So first thing to understand the supportive criteria is the fact that you have to know that ADH is a uricosuric agent. ADH is a uricosuric agent. It's a very good uricosuric agent, which means they reduce the serum uric acid by increasing the uric acid excretion. So which means first point, that's what I'm going to tell about the additional criteria. The serum uric acid will be less than 4 milligrams per deciliter. And second, the serum blood urea nitrogen burn will be less than 10 milligrams per deciliter. And the fractional excretion of uric acid will be more than 11% because of the uricosuric that is present. And number 4, the fractional excretion of urea will be more than 55%. So these are some of the diagnostic criteria. So all these things can be understood in a very simple way, that ADH is a uricosuric hormone. Number 5 tells you that there will be failure to improve, failure of improvement, or even worsening of hyponatremia, with normal saline, that is 0.9% NaCl. There will be worsening of hyponatremia. Number 6, there will be improvement in hyponatremia, with fluid restriction, with water restriction or fluid restriction. So these two are very, very important to be understood, and this has to be explained. So why there is improvement of hyponatremia with fluid restriction? Because you can see very simple logic here. Total body sodium divided by total body water. Here the problem is excess total body water compared to that of the sodium, which is normal. So that is the reason why serum sodium is decreasing and you're developing hyponatremia. Suppose what if I give fluid restriction? If I give fluid restriction, I'm correcting this excess total body water and promoting a normalization of total body water. At the same time, once you correct the total body water here, automatically your serum sodium also must become normal. So that is the reason why improvement of hyponatremia with water restriction or fluid restriction. Then, failure of improvement or worsening of hyponatremia with normal saline. So you are giving a sodium containing solution, but still you are having worsening of hyponatremia. This is a very important clue, especially when you are dealing with the surgical wards. So usually we get call-outs from surgical wards telling that patient is having hyponatremia and we have tried to resuscitate with fluids, but it's actually worsening rather than improving. That itself will give you a clue of SAADH. See the chart, they put a lot of NS normal saline, 0.9% NaCl. Initial sodium was 135. After giving normal saline, the sodium became 125, 124 and it started decreasing serially. So this itself should give a clue that patient is having SAADH. So how this is important? I mean, how you can understand this fact? So for that, you have to do some mathematical calculations. It's simple math. It's not a very tough math. So let us assume a patient who is 60 kilogram man who is having a serum sodium of 110 milliequivalents per liter and he is having SAADH. This is a patient who is suffering from syndrome of inoperable antidiuresis. And his urine osmolality is maintained at 308 because I told you at one patient there will be particular urine osmolality and it will be higher than the serum osmolality. Definitely this is higher. You can see serum sodium is 110 and urine osmolality is actually 308, which means serum osmolality will be not even reaching 225 or 230 here. If the patient's glucose is normal, see the serum osmolality, 110 into 2 is 220 plus glucose, blood urine nitrogen, whatever you add, it's not going to exceed 225 or 230. So 230, 225 is the patient's serum osmolality and 308 is the urine osmolality, which means definitely it's higher than the serum osmolality. It's higher. So this is not correct. So urine osmolality is 380 and it's fixed as well. That's again very important point. I told you already in SAADH it will be fixed and maintained at this level and the serum osmolality will be lower. So now what I'm trying to do is I'm trying to calculate something called total exchangeable cations. Total exchangeable cations. So what do you mean by this total exchangeable cations? Don't worry about that. I'm talking about the sodium, amount of sodium in the body. I'm talking about the total body sodium. That's all. So what are the total exchangeable cations? It is formula is given by total body water multiplied by serum sodium. So here you know the total body water. Total body water is a man. Maybe let us assume an elderly man. In elderly man it is 0.5 multiplied body weight. So 0.5 multiplied by body weight will be the total body water and serum sodium is 110. So I can write 0.5 multiplied by 60 multiplied by 110. It is 30 multiplied by 110. It is 3300 milliequivalents of sodium. So this is the total exchangeable cations in the body. This is the formula. This you have to remember definitely. This is the total exchangeable cations in the body. Now this patient, I am giving 1 liter of normal saline, that is 0.9% sodium chloride. So you have to know that 1 liter of 0.9% sodium chloride has 154 milliequivalents of sodium. This is a very natural thing and every student should know this. So 1 liter of 0.9% NaCl will have 154 milliequivalents of sodium in it. And similarly, 1 liter of 3% NaCl, hypertonic saline, will have 513 milliequivalents of sodium in it, 3 times more appropriately because it's 3%, that's why. So now you can understand I am infusing, by infusing 1 liter of 0.9% NaCl, I am actually infusing 154 milliequivalents of sodium. So, but the patient's urine osmolality is fixed. I told you urine osmolality will work at 308 only in this patient and I am infusing 154 milliequivalents of sodium. So since the urine osmolality is 308 milliequivalents per liter and I am infusing 154 milliequivalents, how much urine is needed to excrete this 154 milliequivalents? It's very simple. It is 154 divided by 308. They just need half liter. That is 500 ml of urine at this particular urine osmolality. It's a fixed one. If they excrete at this rate, at this osmolarity, they just need 500 ml to excrete all 154 milliequivalents of sodium that has come into the body because of infusing 1 liter of 0.9% NaCl. Now, if you have increased all 154 milliequivalents in this 500 ml, which means remaining 500 ml, because you have infused 1 liter of normal saline, what about the remaining 500 ml? That will be conserved in the body because of ADH action, because ADH conserves water. We have excreted all, because that is the idea. Because why? I told you 154 will be excreted here. Why 154 is excreted? Because here the total sodium intake must be equal to total sodium output. That is the basis of SADH. So then only you will result in euvolemic state. That's why I told you, if you damage this euvolemic idea, you cannot do anything in SADH. You will not understand anything. So total sodium intake must be equal to total sodium output. That's what you get in SADH. Very important, crucial point I told you many times. So that's why 154 milliequivalent, if you are giving, that 154 should be lost in the urine. And how much urine you need? Just half liter. But what about the remaining half liter that you have infused through NS? It will be conserved in the body as water. Fine. So this excess water conservation after giving this 1 liter of normal saline is the reason why you are going to get more and more worsening hyponatremia. But again, you can derive that. What will be the new serum sodium? So what is going to be the new serum sodium? Because of that 500 ml excess conservation. Again, you know the formula. The total exchangeable cations is equal to total body water multiplied by serum sodium. But remember, here the total body water has definitely changed now, because initially it was 30 liters. You know, it had a derivation here. Initially, the total body water was 30 liters. But now the total body water is not going to be the same, because now we have conserved this extra 500 ml of water. That is, now the total body water will be 30.5 liters. Then the serum sodium also would have changed because you have excess water in the body. That's why it is a new serum sodium, and that's what you're going to find out. And the total exchangeable cations will not change at all. There will be no change in the total exchangeable cations, because whatever cation sodium that has come inside, you have excreted already with 500 ml of urine. Now, I can write the total exchangeable cations has not changed, that is 3300, and the total body water here is 30.5 liters, and I don't know what is the new serum sodium. So the new serum sodium will be 3300 by 30.5, so which means the new serum sodium must be equal to just 108 milliequivalents of liter. 108 milliequivalents per liter. So you can clearly see where you have started. You have started with 110 milliequivalents per liter of sodium. The sodium value is 110. After giving 1 liter of 0.9% NaCl, you have actually ended up with 108 milliequivalents per liter of sodium, which means you have produced a more and more hyponatremia with infusion of 0.9% NaCl. And again, how much it will decrease depending on how much urine is getting concentrated. That is an evidence of how much ADH is acting and how much water is getting conserved. So everything is linked and looped with each other. So that's why I told you this point, failure of improvement or even worsening of hyponatremia with 0.9% NaCl. Very important point. Fine. After knowing all these things, this is a pro level concept, but still you have understood all this now. So we can go to the treatment of SADH. How you are going to treat this SADH patients. Treatment, remember, first of all, you have to know correction of underlying cause remains of paramount importance in SADH. Correction of underlying cause is really, really important. Why? Because SADH is almost always due to some underlying problem. It's secondary most of the time. So you have to know what is the underlying problem in SADH, and you have to address that. Then only the ADH secretion or whatever ADH hypersensitivity will resolve. And second, initial hyponatremia treatment will not change. Initial hyponatremia treatment and hyponatremia protocol will not change, and we are going to see in hyponatremia chapter. So you have to do that. Either if the pain is having severe symptoms, or depending on acute or chronic, you have to give 3% NaCl emergency. Clear? So number 3, now you can do corrective measures. for SADH. Corrective measures for hyponatremia in SADH. So what are the corrective measures you can give? The first option number 1 is you are going to give fluid restriction. This is the first line treatment. So I can write first line here. That is fluid restriction. This is the first line treatment. I told you the mechanism of how fluid restriction works because you are reducing the total body water. So is there any calculation for fluid restriction? Ideally, it should be less than, goal is less than 800 mLs per day. But you can actually calculate the exact amount of fluid restriction you need by using a formula called urine sodium plus urine potassium divided by serum sodium. If this value is more than 1, you give a restriction of less than 500 ml per day. If this value is equal to 1, you give a restriction of 500 to 700 ml per day. And if this value is less than 1, you can give a restriction of less than 1 liter per day. So this is the ways to find out how much fluid restriction you need. But typically, if you don't know anything, you can just tell fluid restriction should be somewhere less than 800 ml per day. Then second line options. Second line options, you can use salt and urea tablets. You have tablets of salt and tablets of urea. In fact, many practitioners give once in 2 hours. This tablet, salt loading will be there. You might be wondering why we give salt. And as a beginner, it's absolutely okay to know that giving salt means you're going to increase the serum sodium levels. Actually, it's not that mechanism. This salt is not going to directly go and raise the serum sodium. The mechanism is something different. Because I told you in SADH, the patient will be euvolemic. Euvolemic means intake of salt should be equal to output of sodium, whatever, so that the total body sodium will be normal. If you increase the intake of sodium, the output of sodium in the urine also will increase, which means this will promote solute-mediated diuresis. What do you mean by solute-mediated diuresis? They can pull more water and they can excrete in the urine. So what is the problem in SADH? More water in the blood. So this can produce solute diuresis and they can produce more water diuresis, causing excessive water loss and promoting improvement in the serum sodium. So it's something easy to understand, but don't think in a different way that this salt is going to directly go into the blood and increase the serum sodium. They don't increase the total body sodium. They are going to cause diuresis and they eliminate free water from the system. So that's how it works. Urea, again, they cause solute diuresis by the same principle. Urea, they cause solute diuresis. And again, you might ask me, sir, urea, you told it's an ineffective osmole, and how you can get solute diuresis. Remember, again, there are 2 areas where urea should not be considered as ineffective osmole. One is the brain. It's a partially effective osmole. And second is in the kidney. Kidney, again, it serves as a little bit of decently effective osmole. Only in the blood, apart from these 2 organs, from kidney and brain, it is an ineffective osmole. But urea, exceptions are there. You have to remember, in kidney, it's an effective osmole only. So giving urea tablets will promote more urea excretion. Already, SADH patients will have excessive urea. Giving excessive urea, again, will promote more and more urea excretion. And that will take a little bit of water out in it, and they can produce solute diuresis, and they can lose water. Because of that, you might result in improvement in the hyponatremia. Then third line treatment. Third line treatment, generally we prefer Vaptans. Vaptans are straightforward. They are ADH antagonists. Like, they prevent the ADH action on V2 receptors, which is important for the ADH-mediated antidiuretic action. So here, excessive ADH, you can block that action by giving Vaptans. Tolvaptan or Conivaptan. Beware of liver toxicity, especially from Tolvaptan. Then other therapy which is not used nowadays are lithium and demeclocycline. Lithium and demeclocycline. These are the other therapies that we don't really use in the current era. Because what lithium and demeclocycline does, this lithium and demeclocycline, they are going to damage the V2 receptors on the basolateral side. They damage these V2 receptors. So the problem with lithium demeclocycline is, yes, they are going to cause good improvement in SADH, but there is a risk of permanent nephrogenic diabetes insipidus, which means they damage the V2 receptors, means you might result in ADH resistance. Yeah, during SADH, inducing ADH resistance makes sense. But once the SADH is resolved, when the underlying problem is resolved, so I mean, once you have damaged permanently these V2 receptors, you will induce ADH resistance permanently, and they may go for permanent nephrogenic diabetes insipidus. That is the reason why we don't use this therapy as of now. And that is one of, because we are going to see nephrogenic diabetes insipidus, one of the important drug-induced causes are lithium and demeclocycline. So be careful about that. Remember how lithium damages these V2 receptors. First of all, you have to understand lithium is going to enter the principal cell and enter the cell of the collecting duct or the distal part of the distal conduit tubule through ENaC channels only. Through ENaC channels only, this lithium is going to enter. So that is why lithium-mediated nephrotoxicity can be actually reduced by giving amloride, which is an ENaC blocker, which means you prevent the lithium entry into the cells. So I mean, we leave that. So these are the other things that are important to know. That lithium and demiclocycline. These are the 4-line treatment. The most important first line is fluid restriction. That itself will treat in a very good way. And remember, one of the important second-line treatment I didn't tell you, that is usage of loop diuretics. I forgot that it's one important second-line treatment, loop diuretics. That's why whenever I tell this point and whenever I add loop diuretic to a patient with SAIDH, my residents usually get shocked. They usually ask me, sir, why you're adding loop diuretics to this patient? So remember, loop diuretics will be effective only if the patient is having very high serum, very high urine osmolality. Because you are actually having a very high urine osmolality means you're having urine osmolality more than the plasma osmolality. What loop diuretics tend to do? Loop diuretics tend to equalize the urine osmolality with the plasma osmolality, which means they produce isotonic urine. I told you already. Isotonic urine or isoosmolar urine. So here actually what loop diuretics is doing is they are reducing the urine osmolality. I mean, from a higher range to equal to plasma osmolality means it's still like lowering the urine osmolality only. At the same time, loop diuretics induce a state of ADH resistance. How they do all these things is because they induce a state of ADH resistance, and that's what we want in SAIDH. So there is excessive ADH action. So we want to induce ADH resistance in the kidney. That's why we add this loop diuretics. We saw this mechanism in the beginning itself. So similarly, loop diuretics, when they have, they are especially useful when you have a very, very high urine osmolality. They bring the urine osmolality at least to the normal range to equal to that of the plasma, so that at least from a very high range you can bring to a lower range. Clear? So indication for loop diuretics, whenever the urine osmolality is at least more than or equal to 2 times the plasma osmolality. It means very, very high, double that of the plasma osmolality, very, very high urine osmolality. In those conditions, loop diuretics will be very, very effective. Trust me. So these are the treatments. So treatment, fluid restriction, urea salt tablets, loop diuretics, Vaptans. Then you can use the lithium and demiclocycline, which are outdated treatment anyway. Vaptans itself used sparingly. Vaptans, a lot of problems are there. Not only hepatotoxicity, it may not cause like the improvement what you want. It might cause more rapid rise of sodium than you predict, and they can even result in a overcorrection and osmotic demyelination. So Vaptans are little dangerous, but you have to use it in a very guarded way. So these are the treatment options for syndrome of inappropriate ADH. So with this, I think we can finish off the particular chapter, ADH and related disorders, that is part 1. In the next chapter, in the part 2, we will be discussing on the diabetes insipidus and how to approach a case of a polyuria and polydipsia, which is again very important for your exams.